Today our topic is thromboembolism and thrombophilia in pregnancy, because I am talking about there is two topics, thromboembolism and thrombophilia, because you see in this thrombophilia, this is also one of the cause of causing the thrombosis, okay, DVT, and this is also one of the causes of the recurrent miscarriages, okay, thrombophilia ना, ये यही वन ऑफ द टॉप मोस्ट जो होता है ना हॉरिबल कॉज, ये थ्रोम्बोफिलिया होता है. जब भी तो प्रेगनेंसी में वी आर गिविंग दिस एस्प्रिन एंड हेपरिन. So only just want to say that we will cover two topics in one go. So I'm just going to make the marking also. If you will look, it is here. It is one of the, he is talking, 1 second, I will make the lining. Okay, well, give me a 1 minute. So DVT means is venous thromboembolism is one of the mortality, okay, one of the um, leading cause. There are many causes, doctor, we will do inshallah empiric now, only the short one for that one. So they are giving the causes of the mother mortality. So this is one of the leading cause. There are many causes. The top one they are talking about, they divided that one. Suicide in their country is the top one most cause. But along with them, 1, 2, 3, they divided up to 10 like this. So one of the leading cause. This is one of the leading cause of the maternal mortality in the worldwide, now whole world that one. And it was also cause also can cause the morbidity. See, there is a difference between mortality and morbidity. Mortality means mother is bye bye. Morbidity means she is going to have a problem. Okay, so what we have to go, and we will also discuss the thrombophilia. What is thrombophilia? Thrombophilia will be two types: heritable and acquired. Okay, so this is also causing the morbidity and mortality. It will cause both, this thrombophilia, morbidity and mortality, both within and outside the pregnancy. What does this meaning? Means if she is pregnant, within pregnancy she can have a recurrent miscarriage. The top one is that one. And outside the pregnancy she can have a DVT also. This without pregnancy she can have also this thing. So that what he is telling about, two things which is more important for us. This will also cause the DVT. Okay, this thrombophilia. So this is finished. Okay, now we have to know, because you see in the pregnancy what this is telling. This is very important point for the MCQ point of view, because in the early pregnancy the coagulation system of the body is changing, because Allah is making the changes in the coagulation system of the mother. Okay, some factors will decrease or increase. These changes will happen normally. Okay, it is a normal process. So what are the one? These are the changes in the coagulation factors during pregnancy. What it will be? Factor 10, 8, and 1 bilirubin and fibrinogen factor. These are the factors. This will be the variable. These are the changes in the pregnancy. Okay, this will increase. Mostly they are all will increase in the pregnancy. And antithrombin and protein C and S, this will this antithrombin and C no changes, but protein S will be reduced. Okay, and this plasmogen and antiplasmin, this will increase. So see, venous flow velocity will be reduced. Why we are talking about these factors? Because this MCQ sometimes they're very important question, MCQ they are giving. But the most important, this one, fibrinogen. Fibrinogen level will be increased, reaching twofold increase over non-pregnant level at term. Okay, so the fibrinogen level become double. Why we are talking about the fibrinogen level? Because see, in the fibrinogen level, when she is having a this what we call it PPH, or she can has DIC. PPH most of the time is important point in pregnancy. So when she is having a PPH, we are looking for the fibrinogen level, PT, PTT, we will look also for that one. Why? Because these are the thing which will go if they will PPH, and then she can go for the DIC. So the fibrinogen important role to play that one. So please remember this one. Von Willebrand factors will be increased, because this factors von Willebrand, because when she is having a von Willebrand disease, this factor in pregnancy, it will improve instead of decrease. So her the treatment will be decreased, the whatever treatment she is taking it. So right now for us important point of view is the fibrinogen. So we have to remember this factor is increasing. MCQ will come this thing. Okay. So this is the only one we have to understand, that what he say, then because these changes are happening, hemostatic changes are happening. Okay, and what is happening, so there is a increase, so she has a increased risk of thrombosis up to 4 to 6 week postpartum, because it is changes, the changes in the coagulation factors are changing. So this for coagulation factors, what they are going to make it, they will make the DVT. Mostly if she can have a DVT in the 4 to 6 week of postpartum. Why he is talking about 4 to 6 weeks? Because these changes, blood changes, will settle in 4 to 6 weeks. What is happening in this 4 to 6 week period? Because if the changes will not occur, she will having a most important risk of DVT postpartum. And this is the reason you have to understand that when the woman is pregnant, we are doing the risk management, risk factors. We will calculate the risk factors. So according to the risk factors, we will give the score, and this score, according to that score, we will put her for the heparin. Okay, so this heparin in the pregnancy we will put it, or the post pregnancy will put it. This is the thing. Or we can start this heparin in the early pregnancy, or we have to start the pregnancy later on. So this depends upon the score of the lady which we give it. But the most vulnerable period time of DVT is postpartum. Please remember this word. Why? Up to 4 to 6 weeks. Why? I told you, because the changes of the coagulation factor, or the serum coagulation factors are changing. So the most vulnerable time in pregnancy, she has a risk of DVT, but post delivery she has an increased risk. So this will be the MCQ. The most increased risk of DVT is post delivery. Is clear, boss? You understand or not?
जी बिल्कुल बिल्कुल
You are getting it? Okay. You know why I am asking it? Because if you don't understand, so at least you can tell me, and then I can explain it again. I will put this thing in our group also. Okay. Now he is talking about what is the problem. Thromboembolism, already say, is the leading cause of the maternal morbidity in the UK or everywhere in the world. It is the one. If it is in the UK, Pakistan has to be more than that one. So he is talking about how many women died, or this died. This is, it will be that one. It is for, from our point of view, we have to do this empiric report. Okay, so how many women there died, and what are the risk factors? Okay, so he is talking about this is the leading cause. So how this leading cause we can prevent it? Without thromboprophylaxis, the incident of non-fatal pulmonary thromboembolism and DVT in pregnancy is 0.15, 0.1%. So what this meaning? This meaning is that if she has a risk factor, we have to stratify the risk factor. After the risk factors, we have to give her the treatment. Why we are going to give that treatment? Because she has a risk of DVT and pulmonary embolism. The pulmonary embolism is the more fatal one than the DVT. So what is this risk without treatment? She has a risk of 0.1% of DVT and pulmonary embolism in developed countries. See, in developed countries, the rich countries, they have this one. So, and then other risk, this is very important. DVT after cesarean section is 1 to 2%. Okay, and it will increase more risk if she has an emergency cesarean section. So please, this is very important MCQ, that she has an increased risk post delivery, any normal delivery, SVD or cesarean, 4 to 6 week. This is the time period they given. But if we will calculate the percentage in the cesarean section, percentage 1 to 2% no, this cesarean section, it can be elective cesarean section. We have a categories, four categories of the cesarean section. So any category we can consider it. But the more risk is in the emergency cesarean section. This will be the cat 1, category 1, when there is a life threatening to the mother and the baby. So within 35 minutes we have to go for cesarean section. This is cat 1. So please remember all the cat 4, 1 2 3 4, it is already there in the group. So we have to understand that cat 4 up to cat 4. So in cat 1, emergency cesarean section will come. So she has an increased risk, more risk of DVT than the elective ones. Clear? Okay. Now we understand that point. Uh, he say mostly DVT is mostly confined to the late pregnancy and operative deliveries. DVT will come in the late pregnancy and the operative delivery. So we have to understand late pregnancy. It is not in the early pregnancy, not in that one. It will be in late pregnancy, increased risk. Why he is talking about late? Why he did not say about the early pregnancy? Because in the early pregnancy, the body is adopting itself, the physiological procedures in the body, and the baby gravid uterus is pressing the uh, veins and arteries of the body of that lady. So this is stasis. This called stasis. So gravid uterus becoming big, so it is going to cause more stasis. If there is a stasis, DVT will be there. Clear? Okay, my
जी
dear.
और आपने आपने ये भी बताया था कि फिब्रिनोजन लेवल भी 2 times हो जाता है टर्म के ऊपर नॉर्मली,
Hmm.
तो दैट कैन बी ऑल्सो कॉज, और ऑपरेटिव जब डिलीवरी होती है तो फिर स्टेसिस हो जाता है, इमोबिलाइजेशन हो जाती है पेशेंट की,
जी जी
इससे भी इंक्रीज हो जाता है रिस्क.
100% आप सही कह रहे हैं. Because these are the things not for the ratification. These are the things you have to understand. The thing, this is the normal procedure I am telling it. You don't need to go even today. You will read it. You are listening. Tomorrow you will not have a time to read it again. That's the reason I am trying to explain you what is going on there. So you don't have a time in that one day. See, he is telling it in the confidential inquiries into maternal that 2/3 of the antenatal fatal pulmonary embolism, fatal pulmonary embolism, 2/3 of the women's. If she is having a deep vein thrombosis, so this thrombosis will go to the make the pulmonary embolism. 2/3 will go to pulmonary. That's why he is taking. He is a 50, and then over 50% postnatal VET death. See, the thing which we are talking over after vaginal delivery, whatever it is, vaginal delivery or cesarean section, over 50% women will die, because that's I am telling you, most vulnerable time period for the DVT is the post delivery up to 4 to 6 weeks, because after delivery the changes will be there of the stasis will be there, changes will be there, so the thromboembolism risk will be more. Clear? Okay. Now what he is talking about in acute phase, he is just talking. So if there is a acute DVT, DVT will lead to pulmonary in acute cases. Okay, normally acute cases. Acute case will DVT will go up to the pulmonary embolism. This is the highest risk in acute phases. Okay. He say if longer the term post phlebitic syndrome and deep venous insufficiency will affect 70% of the patient with previous DVT within 5 years. This is not important for us. For us, the only important thing is that acute DVT will lead to the pulmonary embolism. That's enough for us. We'll no need to go more than that one. Okay, ji? Okay, so how this will manifest? How we know that this is DVT or whatever the problem she is having? What will be the one? She will say leg swelling. Please remember this word, leg swelling and varicose vein are the vein thing. Some women they have a varicose vein, so she has an increased risk of DVT, and she can say that she is having a leg swelling, and she can say that she is having a varicose vein. Okay, ji, these are the most important thing, and maybe she can have a ultimately skin ulcer in some women. Okay, ji. Okay, ji. He said thus, venous thromboembolism is a major cause not only of the maternal morbidity but also the maternal mortality. Both. It is causing one of the cause. Again, he is repeating. He is repeating that it is one of the leading cause of the death and the problem in the woman. Okay, clear? So we'll continue that one. Physiological changes. See, this the one which we are talking. He say pregnancy is associated 6 to 10 fold increase in the risk of DVT compared to the non-pregnant woman. Okay, 6 to 10 fold. Okay. He said the frequency of DVT is similar in all trimester, but highest in the during the postpartum period. Please remember this word for the MCQ. He says she can have a highest risk in all trimester, first trimester, second and third. But the highest risk period is the postpartum period, 4 to 6 weeks. Please remember that one. Okay. This is another MCQ. Pregnancy is a hypercoagulative state. Okay. This is a hypercoagulative state. Pregnancy is called the hypercoagulative state. That's only one word we have to know, hypercoagulative state, because Allah is the one who is making it that if it is a small cut, the baby will, because baby blood reserve is very small. Okay, so if mother will having a problem, baby will get more severe problem. So Allah is saving everyone. Okay, so these are the fun, the important factors. If you want to remember what are the changes, you can have it here. Okay, only the name. But in this one, the important point is that DVT, Varex VT risk in all trimester is similar, but highest postpartum, 4 to 6 weeks. Okay, and pregnancy is a hypercoagulative stress. These are the three sentences for DVT we have to remember for our MCQ point of view. Okay, ji. Now, see, this is the thing. If you don't want to remember all this blah blah, you just remember these points, practical points. Until now, what we read it, this is the points you will remember that one. What is this one? Pregnancy is a hypercoagulative state. The increased risk of thrombosis begins early in the first trimester and continue until 4 to 6 week postpartum. The postpartum period is the time of highest risk. So these are the three sentences. Until now we read it up to one page of this will be the summary. Okay, clear? Now we'll talk about the pre-existing risk factors. Just we are talking it that we have to do the that some woman will come, we have to do the risk assessment for the woman. So what are the risk assessment? Age we have to know it, more than 35, obesity more than 30, pregnancy parity if she has more than 3 children, if she has a previous history of thromboembolism or thrombophilia, okay, or she has a gross varicose vein and she is paraplegic, she is not moving, and she has a sickle cell disease and medical condition like IBS, inflammatory bowel disease, IBD, okay ji, and nephrotic syndrome. So please remember this one. These are the risk factors. There is a big list of the risk factors in the Green Top guideline, but it will be the same. Highest risk factors and the lowest risk factors and postpartum risk factors. They have given three charts there in the Green Top guideline. If you want, I will put these charts in the our group. You can take from there the group. This one, the chart one is there. But if we cannot remember this big chart, so the small, at least we have to remember this is the Gist means the summary of this three chart. I think it is a two or a three chart. Okay. So if we consider that one, if you remember that one, it is very hard to remember these three big charts. So better to remember the small one. The small one. This is the chart. Okay. So now what we have it here. What are the risk factors of the venous thromboembolism in pregnancy? These above we already talked it, so no need to go in detail. The same thing is written in the words, and better to be write in there. Here it is written there. Okay, ji. So we done it one this one, and then he say how we will prevent the. These are two type another risk factors. These are the mostly the existing pre-existing factors she is having it. There is some other risk factors which are the transient risk factors. What are the transient risk factors? She can have a hypermesis. She is having a nausea and vomiting in the pregnancy. OHS. She is dehydrated. Long haul travel. Journey more than 4 hours. This is the horrible thing. Okay, so this is the one thing, and then another thing is any surgical procedure. She can have an infection like pyelonephritis, immobility, preeclampsia, and postpartum what? Prolonged labor, operative delivery, and excessive blood loss. So these are the transient. What is the meaning of this transient risk factor? It means she has a hypermesis. Hypermesis means she is having a nausea and vomiting. So if pregnancy is finished, nausea vomiting is finished. Some they have a nausea vomiting up to the term, but some mostly up to 13 to 14 week this nausea vomiting has to stop. So that's why they are talking about it is a transient risk factor. So this factor will be vanished. Or she is dehydrated. Maybe she is dehydrated if she will drink water or she take IV. The dehydration will finish. So it will be a transient risk factors. They are not changes there. Okay, clear. So we finish it up to here, then we will go up to this one, provoked or unprovoked. We don't need it. Thromboprophylaxis during pregnancy. We have to calculate the risk of that one. Calculating the risk one, we can start for her the thromboprophylaxis. The score we are talking about, the score, or these are the high risk factors or the small risk factors. So you can check in that one this chart. So according to that one, just remember 2 3 factors from there for the exam point of view, important one. Okay. So and the most important factors is the family history of the DVT. Okay ji. This is the most important factors in there. So we have to give, if she has these factors, she has to have a DVT, and she has a more risk of the low molecular weight heparin. Oh, sorry, uh, we have to use that one in that risk. Okay, as a thromboprophylaxis. See, my friend, there is two type of treatment we have to give it. This treatment, thromboprophylaxis and therapeutic. Therapeutic means as a treatment we are giving as a treatment, because she is DVT, and as a treatment we are giving it. Why we are giving it? But if she develop DVT during pregnancy, she has a risk, she has a chance that this DVT will finish after delivery of the baby. So that's what we are talking about, that maybe it is supposed to be a transient risk factor, that the baby delivery is finished, baby delivered, the chances will finish. But if she has a family history, she has a risk factor. Some hereditary genes will be there, so she can have this problem. Okay, ji. Okay, ji. So what he is talking about, some they can use it graduated elastic compression stockings. The socks they will wear. Some they use it. Okay, is recommended in all women with the previous DVT or the thrombophilia during the pregnancy and 6 to 12 week postpartum. So what he is talking? He is telling that we can give her the heparin. Okay, along with heparin, she can wear that stocking. This stocking like a in the what cold season we are wearing the socks, so it is like a sock one up to whole heel it is covering, especially the calf muscles. So it is making the compression there. So that's why he's talking that we can use also the stockings. Okay, stockings. Antithrombotic, thrombolytic stockings, they call it there. Okay, so what he said, this way he fit it. This will reduce, we don't need the mechanism here. So he say, only upon this one we talk about. Then he say, postpartum thromboprophylaxis. So postpartum thromboprophylaxis, I just told you that it is the postpartum up to 4 to 6 weeks. It is the most vulnerable period, highest risk factor for the thrombosis, thrombosis. So that's what we have to continue our this we are giving heparin even post delivery 4 to 6 weeks. That's the one what he wants to say. We are going to collect those factors again. He is talking about we don't need it, we have to lead it that chart. That's all. And then he say how you are going to diagnose the acute thromboprophylaxis. Okay, he is telling diagnosis of DVT is unreliable. Means we will suspect of having DVT or PET according to the investigation and diagnostic imaging and the patient sign and symptoms. This depends upon that one. So DVT, high sensitivity and specificity means highly we can diagnose with patient complaint or symptoms with that one. Okay, so what we have to do, we for the DVT, the best management is the compression ultrasound, the best one. Okay, this is the first investigation for the use of suspected DVT. Please remember this has to be the compression ultrasound, compressed ultrasound. This is called it compression ultrasound. Na? This is the most important one, the scan. If the scan is negative, but we have a clinical suspension, I am talking, this is the same words written in the guideline also, the word by word written in the guideline, but this is a mixture of the many guidelines, they put that one. So he is telling if ultrasound is negative and we are suspecting DVT, okay, that we have to do that one. Means on our suspicion, the first scenario is there. Second scenario is that if the scan is negative but we have a clinical suspension, the treatment can so what we will do, we have a low clinical suspension, low, highly not suspecting, we are not highly suspecting that she is having a with her sign and symptoms, na I'm talking. So but ultrasound is negative, this complex color na Doppler is negative. So but clinically we are thinking, 1 minute my dear. It's clear for you until now or not? Hello, boss,
जी मैम, जी 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 बिल्कुल,
you understand? Because
जी
you
जी
know the scenario, if you look, the scenario of DVT is all the same, it is coming like this. Okay, so if the scenario is telling that the scan, Doppler scan is negative, duplex scan is negative, okay, they did not find DVT is there, but clinically low suspicion, not severe suspension or highly suspected, low, low. Please remember that word. This is low, low clinical suspicion. Then what we'll do, we'll stop the treatment. But if we are highly clinical suspicion, then what a negative scan, but we have to continue the treatment. Okay, and then we will repeat the scan in 1 week. Please, this is a very important MCQ. Remember this MCQ point. The one point is that if we are suspecting, first line of investigation of our DVT is the duplex scan, compression ultrasound scan. This is the color Doppler, we will do it. But if the color Doppler is came negative, it has to, this scan has to be done by the specialist. Okay, this specialist, he say he did not find the DVT because it will be a greatest crime, because women can die if we will misdiagnose this DVT on ultrasound, first investigation. So this is a great responsibility for the doctor who is going to do that one compression ultrasound. So he cannot lie. So it means as ultrasound, this ultrasound is negative, but low suspicious. Please remember, low suspicious. We will stop that treatment. We will not continue that treatment. But we have a high suspicious, clinical suspicion that she is a leg swelling, red area of the swelling. Okay, and even touch she get having a pain, cough pain. So this is the highly suspicious timing symptoms of the patient that she is having a DVT risk. Okay, so if ultrasound is negative but high suspicious is there, then we have to do the continue the treatment. Please, when we will stop the treatment, when we will continue the treatment, and we will do the ultrasound repeat in 1 week time. Clear for you people? देखिए डॉक्टरा आप यू रिमेंबर वन थिंग, आप ये रिमेंबर करें कि उसको पेशेंट को हमने करना फर्स्ट लाइन इन्वेस्टिगेशन की डायग्नोस हमारी क्या होगी. फर्स्ट लाइन इन्वेस्टिगेशन हमने करनी है उसका कंप्रेशन अल्ट्रासाउंड. ओके जी, फर्स्ट लाइन हमने कर लिया. अब करने के बाद क्या हुआ, क्यों हमने किया था ना अल्ट्रासाउंड, इसलिए किया था ना कि उसको भाई प्रॉब्लम था, वो कंप्लेन कर रही थी. तो वो जो कंप्लेन कर रही थी उसके बेसिस पे हमने उसका अल्ट्रासाउंड किया. या एक्सपेंसिव अल्ट्रासाउंड, दिस इज द वन. So ultrasound came negative. There is nothing. They did not find that anything in the DVT. So what they will do it? She has a low clinical suspicious. We are making it. So we will stop the treatment and let to see observation. Okay जी. But अगर high suspicious हो रहा है हमको, अल्ट्रासाउंड फिर भी नेगेटिव आया, तो हमने क्या करना है, अल्ट्रासाउंड को कंटिन्यू करना है. सॉरी, अल्ट्रासाउंड को नहीं, ट्रीटमेंट को कंटिन्यू करना है और उसका अल्ट्रासाउंड 1 हफ्ते बाद करना है. क्लियर बॉस? हेलो.
जी मैम, बिल्कुल मैं सुन रही हूँ.
क्योंकि ये बहुत इंपॉर्टेंट MCQ है माय डियर, डोंट मिस दैट वन, एंड इट विल कम लाइक दिस. So we finish that one. So he is talking about the treatment. Okay ji, if she has a previous DVT, not on long term warfarin, what we will do it, this is the one table. So this will be with you. I will send you this article and then you can make that one to read that one. Okay ji. So this we are not going to make the timing. This is all the things are there. Okay, this is along with the table one, means this will be the one. We have to what we will do, antenatal, 6 week, postnatal, up to that time which time, just have a reading, only make a reading to understand, no need to go in detail, because you know this question for the exam point of view, theory point of view, I hate these questions, but what can we do, we have no way. If she has a previous DVT, plus minus thrombophilia, and she is already taking the warfarin, okay, so what we'll do? We'll do the antenatal high prophylactic or therapeutic dose of low molecular weight heparin and postnatal warfarin. So he is telling if she has a previous DVT and she is or plus minus thrombophilia and she is taking warfarin. So if it is this is the case, she is having it. So what we have to do it? We have to do antenatal prophylactic or therapeutic high prophylactic high dose of heparin, or we have to do the therapeutic dose. Okay, so in between those we have to choose, and when she deliver we will continue the warfarin because she is taking it. She is a known case of DVT. And other scenario is that she is have a previous recurrent VET, not on long term warfarin, but she has a history that she is a long term VET, but she is not taking warfarin. So what we'll do, antenatal and 6 weeks postnatal prophylactic we will do. So see, there is a difference between the previous DVT and no longer on warfarin. This is the difference. Please remember that thing. The first one is that she has a history of DVT, previous DVT she has, and she is taking warfarin because of that problem. But other scenario is that she has a DVT but not taking a warfarin. She is not on warfarin. history. She is only having a history and she is not taking any treatment. So what we will do, we will give her antenatal and postnatal this heparin. But if she is having a previous DVT or long term warfarin she is taking treatment or she is not taking treatment. So please remember, this is the most important difference we have to remember by heart. Now he's talking about the thrombophilia. He says if she has a previous DVT and she is having a thrombophilia, and she is having a previous DVT and the family history of VET. Okay, so what he is talking about the types upon that one. So we will do that antenatal and postnatal. So this is the all about the story of that one. The most important is story. Another story he changed it. He say if she has a single previous provoked VT without thrombophilia and she has a family history or other risk factor, what's this meaning? She is single previous provoked DVT. Provoked DVT without thrombophilia means she don't have a thrombophilia, but she has a provoked. Provoked DVT means previous history. Means she is taking oral contraceptive pills, so she has a DVT. So when she stopped the oral contraceptive pills, DVT gone. So there is no thrombophilia. So what we'll do, she will only need the postnatal thromboprophylaxis. Okay, ji. Or if we will give her antenatal aspirin only. This is the thing. That's the difference between up and down. So up one is that previous DVT with thrombophilia and she's taking warfarin. Then we have to do this high dose or low dose of this heparin up to 6 weeks or whatever. But if she has a asymptomatic means this is the one which we read it. The previous she is having a provoked DVT due to any reason provoked DVT, and she don't have a thrombophilias, but she has a family history or other risk factors. Then she has to give. We have to give her postnatal. Clear? So we finished up to that one here. Pulmonary embolism, we will now do the pulmonary embolism. It is little we have to know about this thing, we don't need it, that thing. One thing is here important, we have to, I forgot to tell you. He say venography can be done, is associated with fetal exposure because you know venography we are doing with X-ray, CT scanning, okay, and MRI. CT, if we will do venography, CT scanning, and MRI, then she has a unilateral venography will do. So she has a exposure to the X-ray. Now, how much she will be exposure? 0.31 rates without shielding. And I remember with shielding, I think it is 0.1. We already learned that one. I think it is 0.1 rates without shielding. And with shielding, with shielding 0.1. Without shielding is 0.3. So see how much difference is there. So he is talking about that in utero exposure to less than 5 rates does not result in fetal loss or congenital abnormality. Please, these wordings are very important. Don't forget these wordings. He is talking about that if she has been exposure in utero, any X-ray has been done previously for any reason, she can have a no risk of up to 5 rats. Okay, she has it no risk fetal loss or the congenital anomalies, but associated with increased risk of childhood malignancy. Clear? So we finished DVT. Any question? हेलो
ठीक हो गया जी 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 ठीक हो गया
ओके जी। अब हम करते हैं पल्मोनरी एम्बोलिज्म का। तो पल्मोनरी एम्बोलिज्म में हमने क्या करना होता है, इफ पल्मोनरी एम्बोलिज्म इज वी आर सस्पेक्टिंग इनिशियल वी विल डू ईसीजी, ओके, electrocardiogram. The initial investigation for the pulmonary embolism, ECG, electrocardiogram, chest x-rays and arterial blood gases. These are the investigation we are doing if we are suspecting for pulmonary embolism. Okay ji. EEG, and that one we are doing the Doppler complex ultrasound. Here we will do the electrocardiogram, ECG, and chest X-ray and arterial blood gases should be performed to exclude other respiratory diagnosis. This is talking about the DVD, differential diagnosis, DD. Okay, ji. But he say, however, these investigations are insufficient on their own to exclude or diagnose PET. He is telling about whatever the investigation we are doing, they are not 100% accurate to diagnose that thing. Okay, so what he is talking about, all the tests are normal with, he is talking about pulmonary embolism, only the same treatment, there is nothing more than that one. Here, a practical point, you have to remember these practical points. What we have it. A woman should have the risk of DET assessment. At the booking, we'll do it, and this risk should be reviewed and when admitted antenatally and labor and postnatal. My dear, this red practical points, we have to remember by heart these points. Clear? So we finish it here, my dear, and we don't, we has, sorry, this one question is coming here. He says CTPA, okay, is preferred to perfusion studies for initial investigation when there is a chronic lung disease or abnormal chest x-rays. So remember this word, I have to tell you. See, first investigation what we are doing it for this, we are suspecting pulmonary embolism. This one we will do it, that one, sorry, this one, these are the lines, I will put the line. Chest x-ray, ECGs, chest x-rays and arterial blood gases. This we have to do first. Then he is talking about if, sorry, CTPT we will do it when the chest X-ray is abnormal. We will, if the chest X-ray is normal, we will not going to do it CTPA. But if it is abnormal, then we will do it. Then VQ scan. What VQ scan? This is very important MCQ. This will consist of childhood cancer. If we'll do VQ scan, okay. If it will highest risk of the childhood cancer between the age of 15 compared to CTPA. CTPA is a problem with the mama. She has an increased lifetime, increased risk of breast cancer, and can increase 14%. We don't need this one, but for us, important one is that this is very important MCQ. Please remember, very important MCQ. What CTPA, it will cause the breast cancer to the mama, and VK scan will make the problem for the baby, and baby will get the childhood cancer. This is the most important thing we have to have it there to understand. And other D dimers elevated in pregnancy due to the physiological changes. Okay, so it is also increase in preeclampsia. So right now we don't need this thing to read it. Up to for us, our reading is up to here. Clear, my friends?